Welcome, everyone, to the Allegheny Health Network Innovations in Pain Management CME course, which we will be presenting in conjunction with OTW Broadcasting. Our faculty and I are front runners in this exciting field of pain medicine. And of course, we will review spine neuromodulation therapies, deep brain stimulation, and for chronic pain, as well as other indications. Indications of a selective small molecule inhibitor as a novel analgesic, the impact of a virtual reality on chronic pain, which I think is really exciting and a new area that I'm exploring myself. And I think that will be something you'll see more of. Neuroablative procedures for patients with cancer pain, which is a big issue for those who suffer, as well as a brave new world of DNA-decoy prevention of acute and chronic post-surgical pain, which is cutting edge. So that DNA-decoy is going to be, I think, just an amazing concept. And other current concepts in pain management reimbursement, which is obviously important to have patient access. Our first presenter is Dr. Ahmad Raslan, who is the Vice Chair for Clinical Affairs and the Director of Clinical Operations at Neuroscience at Oregon Health and Science University. Ahmad, it's a pleasure to have you with us. I'm certainly excited to hear your talk, and I think your reputation certainly is wonderful, and we look forward to your thoughts on this important topic.
Hello, good afternoon and good evening or good morning, everyone, for whichever time zone you are. First, I'd like to thank Dr. Tim Deer for inviting me to present in this course. And I'm pleased and honored to present the CNS, the Congress of Neurological Surgeons, Systematic Review and Evidence-Based Guidelines on Neuroablative Procedures for Patients with Cancer Pain. I was honored to be the chair of the task force that prepared that document, which will present the current evidence and the current recommendations for use of CNS ablation for treatment of patients with cancer pain. These are my disclosures, and none of them are relevant to the content of this talk. So the guidelines were published in March 2021, this year, in the Journal of Neurosurgery. This is a culmination of work that lasted about 3 years, started actually towards the end of 2017 and continued all the way to 2021. And on the left-hand side, you see the members of the task force, which is formed by members of the joint commission between the AANS and the CNS. So as you all know, the cancer pain has a huge burden. About 60 to 85% of patients with advanced cancer have pain, and cancer pain is either not diagnosed or inadequately treated in 40% of the patients. But 1/3 of hospice patients reported pain at their last visit, and they wished to have it better controlled. And despite efforts to improve end-of-life care, cancer pain remained and was reported as worse controlled between 1998 and 2010. Central nervous system ablation for pain control is grossly underutilized, and when it's utilized is actually delayed, so we get called for it later. So this is the statement that we kind of outlined as a task force. While the general trend in the last few decades of the 20th century has been a departure from ablation of the nervous system because of the use of intrathecal opioids or oral opioids, CNS ablation for cancer pain has been reintroduced as a treatment option in select instances such as cordotomy for mesothelioma with great efficacy. On this basis, this clinical practice guideline for the use of neurosurgical ablation for cancer pain was developed. This guideline will be updated as imaging improves and technical expertise expands and lesioning modalities continues to evolve, and if new evidence actually is introduced. So the methods adopted is a standardized method for development of guidelines by the Congress of Neurological Surgeons, but it basically was broken down into 6 steps. One is the writing group formation with question establishment. The second is literature research. The third is study selection and eligibility criteria. Fourth is data collection process. Fifth is rating quality of evidence, which includes production of evidence tables, as well as making recommendation and final revision plans. So the joint section on pain formed a task force for the formation of the guideline of neuroablation, which was honored to chair and form a key question using the PICO methodology. The first question was for patients with unilateral somatic nociceptive neuropathic body cancer pain, which is actually, this is one of 4 scenarios that we envisioned as encompassing for all patients with cancer pain. For patients with unilateral somatic nociceptive cancer pain, is cordotomy or dorsal root entry zone lesioning or thalamotomy or mesencephalotomy or rhizotomy most effective for pain control and reducing risk of potential complication? The second question was, for this particular category, was in patients with unilateral somatic nociceptive and neuropathic body cancer pain, what are the outcomes following cordotomy, DRES, thalamotomy, mesencephalotomy, and rhizotomy that indicate efficacy of pain control? So these are the PICO questions for the first clinical scenario. The second clinical scenario is craniofacial cancer pain. For patients with craniofacial cancer pain, is trigeminal tractotomy, rhizotomy, or nucleus codalis DRES most effective for pain control and reducing risk of potential complication? And here by rhizotomy, we mean cranial nerve rhizotomy, such as trigeminal rhizotomy. The second question for this particular scenario was, in patients with craniofacial cancer pain, what are the outcomes following trigeminal tractotomy, rhizotomy, and nucleus codalis DRES that indicate efficacy of pain control? The third clinical scenario is a midline subdiaphragmatic visceral cancer pain. And similar questions for patients with midline subdiaphragmatic visceral cancer pain. Is myelotomy effective for pain control and reducing risk of potential complication? And in the same group, what are the outcomes following myelotomy that indicate the efficacy of pain control? And the last clinical scenario is disseminated cancer pain. Similarly, the two questions was, is cingulotomy effective for pain control and reducing potential complication for disseminated cancer pain? And second is, what are the outcomes following cingulotomy that indicate efficacy for cancer pain? So these are basically the questions that are based on PICO format. The second step was to undergo literature search, which we used a librarian assigned by the Congress of Neurological Surgeons. And basically, this is the EM-based search, and these are the search criteria, including ablation, neurosurgical ablation, dorsal root entry zone, ablation therapy, cordotomy, as plus pain. So this is the search criteria, and we did the same thing with Cochrane Central. We have identified several eligibility criteria for literature that would be included in the systematic review. It has to describe ablative neurosurgical procedures for cancer pain. Studies described other pathology in addition to cancer pain were not excluded, but were scrutinized to include only patients with cancer pain identified within those studies. It has to present quantitative results. It had to include at least 5 human subjects older than 18 years of age treated for cancer pain. The clinical outcome had to be analyzed rather than in vitro analysis. And patients with, these were not in vitro studies for novel molecular markers. They were not biomechanical studies and were not performed in cadavers. And the study were in English between January 1st, 1980 and April 24th, 2019, and it had to be in English. So, a footnote, the authors did not include systematic reviews, guidelines, and meta-analysis conducted by others. These were cited and read and included in the discussion, but not in the evidentiary tables. This is a PRISMA flow chart that showed that we identified 14,646 records and abstracts, and the excluded abstracts were 14,457 to have a 189 full text article assessed for eligibility, which further excluded 131, and the studies included in the synthesis were 58 studies. These are the evidentiary table classification system that uses class 1 evidence, which is evidence from more than one well-designed randomized controlled clinical trial, including overview of such trial, and as such will have a level 1 recommendation. Class 2 evidence is evidence from more than one well-designed comparative clinical study or non-randomized study or case-controlled studies or prospective cohort. Class 3 evidence is evidence from case series or comparative studies with circle control, and the corresponding level of recommendation is level 2 and 3. This is an example of an evidentiary table created for the procedure mesencephalotomy, in which you identify the author and the year, as well as the class of evidence assigned by the task force, and the summary of the outcome and complications, the rationale for grading. So what are the results? For unilateral somatic pain, there were 5 procedures that could be employed to treat unilateral somatic pain. For rhizotomy, both in its percutaneous radiofrequency or chemical and open surgical form, we found that it may be used to treat patients with unilateral body cancer pain and occasionally bilateral cancer pain, but outcomes such as sensory deficit as a result of rhizotomy and occasionally motor autonomic deficits should be considered. So you could use it, but you have to be aware that the peripheral nerve or spinal nerve you're ablating could have a downstream effect on the motor or sensory function. The strength of recommendation for rhizotomy was level 3. For DRACE, there was insufficient data to make a recommendation regarding the efficacy of DRACE. As for thalamotomy, which can be broken into 2 types, either mediodorsal or basal thalamotomy, using radiofrequency or radiosurgical, this can be used to treat patients with unilateral somatic or nociceptive neuropathic body cancer pain. Potential complications included transient diplopia, confusion, or delirium, and should be considered. The strength of recommendation is level 3. Mesencephalotomy is another procedure that aims at destruction of the spinal thalamic tract in the midbrain, and this also can be used to treat patients with unilateral somatic nociceptive neuropathic body cancer pain, and especially as an alternative to cordotomy when pain involves dermatomes above C5. Potential complications should be considered, including gaze palsy and 0.5 risk of mortality when performed bilaterally. The strength of recommendation for this particular procedure was level 3. Cordotomy. And cordotomy actually stands alone among all the procedures. Percutaneous image-guided cordotomy may be used for the treatment of patients with unilateral somatic nociceptive and neuropathic body cancer pain with an expected durability for at least 6 months. Potential complications included temporary paresis and those should be considered. Additionally, cordotomy could be done bilaterally in select cases. The strength of recommendation for cordotomy is actually level 2 due to the presence of 1 randomized trial. When we move to the second clinical scenario, which is craniofacial cancer pain, for all 3 procedures, which are cranial nerve rhizotomy, and nucleus codalis DRACE, and trigeminal tractotomy, there wasn't sufficient evidence to recommend one procedure over the other for pain control in patients with craniofacial cancer pain, and as such, there were no recommendations. As for midline subdiaphragmatic visceral cancer pain, which is the third clinical scenario, myelotomy in its both forms, open or percutaneous, may be used to treat patients with midline subdiaphragmatic visceral cancer pain, and the strength of recommendation was level 3, but there wasn't enough evidence in the literature to suggest that the size of myelotomy lesion is important or to favor open versus percutaneous method. And the last clinical scenario, which utilizes cingulotomy, that is the disseminated cancer pain, cingulotomy may be used in patients with diffuse cancer pain associated with metastatic disease. The risk of postoperative cognitive and behavioral problems should be considered and discussed, and the strength of the recommendation here is level 3. Based on that, we find that cordotomy stands alone because it's the only one that carries a level 2 recommendation due to a presence of 1 randomized controlled trial. It has received the highest level of recommendation. Additionally, it's the most performed, most studied, and most reported procedure worldwide, and there's a name recognition and there's familiarity with the procedure. There was a 1 randomized trial, and it is an ongoing multi-center randomized controlled trial for cordotomy funded by the NIH. In conclusion, to wrap this up, for CNS ablation for cancer pain, the most common procedure is supported by level 2 evidence and recommendation. Most of them are done using minimally invasive techniques. There's a short hospital stay and safe. They're effective in certain conditions such as unilateral body pain, face pain, and midline visceral pain. Patients usually present too late. As soon as opioid toxicity is reached, refill is actually needed. Durability is about 1 to 2 years, and many academic centers has the expertise. Again, thank you so much for giving me the opportunity to present the guidelines, and I'll be happy to take questions. Thank you.
Thank you, Ahmad. That was a perfect introduction to the innovative world of pain management. Next, we have Dr. El-Saad, who's a personal friend of mine, faculty member of the Department of Anesthesiology at the University of Wisconsin, where I've had the pleasure of visiting, and where he's part of the interventional pain program. Dr. Al, my friend, thank you for joining me today, and look forward to your thoughts.
I'd like to start with thanking Dr. Deer for the invitation to present our article on the utility of electrical neuromodulation for treating chronic pain syndromes in the pediatric setting. So thank you all for being here to listen to this presentation as well. To start with introducing myself, my name is Ala Abdi El-Sayed. I'm the medical director of UW Health Pain Services, and I go by Al. And I'll be presenting our article about neuromodulation in the pediatric setting, which was a systematic review. This is my conflict of interest. And I will start with talking about background. So we do have a children's hospital here at the University of Wisconsin, and I personally performed implanted a spinal cord stimulator in some teenagers. Not a large number, but a small number of cases. And we came one day to start thinking about what is the scope, like what others do in other places when we talk about neuromodulation for children. So, and I'm specifically here, I'll talk more about spinal cord stimulators because we know that people implant the baclofen pump in children. For example, it's a common practice, but when it comes to spinal cord stimulators as a form of neuromodulation, we really don't know much out there. And we had very good results with the cases. And as we have grown our pain program in the pediatric setting, we are seeing more and more need to treat patients with spinal cord stimulator because they fail or other treatment modalities. So here we wanted to look at the chronic pain syndromes in children who can carry significant threats to psychological well-being, opioid overuse, functional impairments, and severe disability. And I would like to keep this in mind in that same impact the pain has on adults is probably the same or worse in children. It doesn't, particularly they are in a development stage they have education needs, and they can cause even more damage to them when they have severe chronic pain syndrome. And where there are a lot of studies that show the efficacy of neuromodulation in treating chronic pain, if we look through the literature, majority of those studies were done on adults. And the concept we wanted to think about is, can we translate same results into children? So basically we wanted into literature to explore more and more about what's published in the pediatric setting. So this was a systematic review to look at the existing clinical experience of implantable electrical neuromodulation in treating chronic pain syndromes in the pediatric population. We performed this systematic review using the conventional PRISMA methodology, which is probably one of the most common methodologies used for this kind of reviews. It brings all articles available, and we can grade the risk and evidence. And our primary outcome parameters collected were analgesic relief and functional benefits. Additionally, previous intervention attempt neuromodulation parameters and limitations were also collected and reported in our article to have more an understanding about why those children got to neuromodulation, what they tried before, and again, what limitation they had before and improvement they had after the implant. So we came up, actually, we found very small number of studies, 11 studies basically were identified which described 19 patients. So as you can see here, the number is very small, though there is nothing much published on this setting. And it's very important to note, it doesn't mean it's not published that it is not happening. There are probably other pediatric practices that do this kind of procedures in children, but they did not publish the literature. And that was one of our goals when we published our work, is to start the discussion and motivate other investigators to publish their work about neuromodulation in the pediatric setting. The cohort was mostly adolescents, 18 out of the 19, who suffered also mostly from CRPS. And as we see the number, so we didn't see really younger children, but were adolescents for the most part. Nearly all patients reported significant pain relief and functional recovery following neuromodulation. And there was no severe complications associated with any of those patients. Basically, we wanted to conclude that there are children with chronic pain refractory to standard of care approaches who could be considered for neuromodulation interventions. And sometimes when we think about neuromodulation, we think it's not an option for children, or maybe it's not a common option for children, but this is not the case. Some children have severe chronic pain conditions that are refractory to all other, I would say, standard approaches of care. And we have to start thinking of other more invasive options to treat their pain, and neuromodulation can be one of them. The existing data, which was limited and from a low tier of evidence, suggests that these interventions are relatively safe and provide meaningful pain reduction and functional improvement. Again, hard to generalize that conclusion because the number of patients, is small, and these are very small studies and done at a very small scale. But I hope from this article, we will encourage other investigators to publish larger data, so at least we can compile this data one day and come up with a better conclusion about the safety and efficacy of those procedures. I would like to leave with you also, it's very, very important to understand that when we do spinal cord stimulator or electrical neuromodulation for children, there are many other parameters we have to think about different from adults. So here we recommend the very careful consideration of the pubertal growth spurt prior to device lead placement, given the possibility of inferior lead migration with physiologic growth in patients with spinal cord stimulator devices or foraminal extrusion in patients with dorsal root ganglion stimulation devices. And this is something we have to keep in mind. We might place the spinal cord stimulator, but then we have to consider those factors as we make the placement about the growth they will go through, the potential physiologic migration that may happen to those patients, the need for changing the batteries. Also, if we place dorsal root ganglion stimulator, we have to consider, again, that physiological changes that will happen at the spine and foramens or foramina, and understand really how can we adjust for this. This will require at least more regular follow-up and transitioning the children to an adult program that has very good setting for following up on those devices. So if we have someone who will implant the children and do not have a path to have continuous care in adults, that's a consideration. The provider should have a path to another program so those children can go to as adults. In addition to continuous monitoring of the migration, lead placement, and location, and potentially be ready for lead revisions or reviving the device at certain age if the physiologic growth caused significant migration or a change in the location of the leads, and in turn a change in the stimulation. I would like to thank Dr. Deer again for the invite, and I would like to thank you all for attending this CME event. And I will give it back to Dr. Deer to continue our webinar.
So thank you for that interesting program, Al. That was spectacular. Presenting next is me. For those of you who don't know me, once again, my name is Timothy Deer. I'm an anesthesiologist by training, although I haven't done anesthesia in many years. I practice full-time interventional spine. I'm the president and CEO of the Spine and Nerve Center of the Virginias in Charleston, West Virginia. And my pre-recorded talk will be on spine neuromodulation therapies. Particularly, I'm going to focus on dorsal root ganglion stimulation, an area where I've spent a lot of my research time over the past few decades. So I hope you enjoy my talk. These are my faculty disclosures, particularly in this case, this presentation is about dorsal root ganglion stimulation, which was developed by Abbott through spinal modulation. But I will talk about a few off-label things today as well. I'm in West Virginia. I'm president of the American Society of Pain and Neuroscience, chairman of that society, actually, and past president of the INS. I'm in full-time pain practice with an academic tilt, where we do research and development for things like dorsal root ganglion stimulation, many other waveforms over the years, and things like peripheral nerve stimulation, intradiscal therapies, and interspinous spacers. I'm going to talk today about dorsal root ganglion stimulation. What does it do? And really, what's the purpose of the DRG? And I really like to relate it to this picture. This is Ironman Hawaii. One of my favorite hobbies is triathlon. And I'm on the beach in a yellow swimsuit here with an orange cap. I think you might be able to pick me out if you look to your right. And the DRG actually takes all the signals from the periphery, which all those swimmers are on that beach, and it filters it into a very dense but uniform signal via a very unique mechanism that really transmits it to the spinal cord, then to the brain. So the DRG is a filtering system that processes information to really give us the pain signal. The DRG always lies below the pedicle. Certainly as you go cervical to thoracic to lumbar, For the neurosurgeons in the audience, you know, it certainly can vary. It's more medial as you go up, it's more lateral as you go down. And that's sort of the process of the DRG. And when it's malfunctions, so what happens is people get injuries like these patients. This is something called complex regional pain syndrome, where an injury occurs, and you see there the swollen, erythematous, discolored extremity that often becomes allodynic. And allodynia is a process where a fiber signal becomes extremely annoying to the nervous system. And that's because the DRG is not currently filtering properly because of a neurological abnormality. So let's look closer. This is an electron microscopy picture of the DRG, and that's such a complicated thing. When you have a tissue injury in the periphery, whether it be a fracture of the limb, whether it be a nerve injury during back surgery when you're out actually on the nerve root, anything that's actually distal to the DRG causes a neuroinflammatory inflammation. And that inflammation then leads to a hyperexcitable membrane state, really. So it's different than the spinal cord, and then it contains bundles of nerves called the primary sensory neurons. These primary sensory neurons are special because they are able to influence pain signals as they travel from the periphery to the brain. And so as that occurs from A delta C fibers and other fibers, you see a change in the brain process. Now, this is a classic animal model where you look at a peripheral nerve field injury, and then you put electrical recordings at the T-cell junction, both distal and proximal to that area. And what you find is an electrical stimulation changes the impulse filter in the T junction, the primary sensory neuron. So we know from the animal model that an electrical current at the DRG will change the amount of signal that goes through. And that's really the whole theory and the process behind dorsal ganglion stimulation. So the mechanism of action is known. Unlike many things in neurostimulation, including in some cases even brain stimulation, where the mechanism isn't known, DRG, the mechanism of stimulation, is known quite well. And I think that's really important. And when it malfunctions, I showed you before, this is a classic case of a horseback rider having a really complicated fracture leading to this syndrome. Now, does it work? I did the first study in the world back in 2010, a 10-center study for 3 days. And you see here on the right, the cartoons depicting the reduction in pain, both in leg, in foot, and in back. And this was a study to really get FDA approval to go forward with a larger study. This was a feasibility, because before this happened, doctors would stick leads out the foramen that were normal leads, not meant for the foramen. They would do paddle leads and things of that nature that were not meant for that area, and that would lead to nerve injury. So this was really the first look at a very novel technique to do the DRG. Now, we knew where the DRG was, and you see on this slide, particularly on the left of the slide at L4 and L5, a small little lead that looks nothing like a spinal cord stimulator lead that goes above and drapes the dorsal ganglion. And this is really what we developed over time, was a process to stimulate the DRG, specifically missing the nerve root and missing the spinal cord. How do we know we're getting the DRG? Well, the amount of energy needed is in microamps. It really is much less energy than the spinal cord or the peripheral nerve. And it's very unique in that way. And this is what it looks like. And here you see leads going in through an epidural placement via the epidural space. So this is a percutaneous approach currently. There's no current paddle lead for this, although it's been designed and is in development, something I've worked on for the last decade. So we take this sheath system that goes in, and we actually put the lead in the sheath, because the lead is so much smaller than a normal stimulator lead. It has to go through this small sheath. We go through the ligaments in the transforaminal region. So many anesthesiologists and physiatrists really don't realize, I know the neurosurgeons do, that there are ligaments around that foramen we have to navigate through. And I always say it's a finesse procedure, not a procedure of strength. Once we've taken that sheath to the top of the foramen, just below the pedicle, we drape the nerve, and we actually take it out and remove the sheath. As we remove that sheath, we leave a loop of slack in the epidural space so it won't move. Now, does this work? This is a study that led to FDA approval that we led along with myself, with Dr. Levy and others. And what we found is that dorsal ganglion stimulation was much better for not only complex regional pain syndrome, but also for causalgia, which is nerve injury from any cause where you can actually name a specific nerve. That's one of the reasons we're seeing a growth in this field right now in things like pelvic pain after pudendal nerve injury, or pain after trauma. So we're seeing more and more success with DRG in those cases. Pain after knee replacement or hip replacement, where there's some form of nerve pain, despite an excellent surgery, this is getting to be a more commonly applied use. The ACRE study had 76 patients in both groups, going out to 1 year and looking at a 3-month endpoint for pain, but a 12-month endpoint for safety and pain. And what we found was the DRG group was superior, not only for safety, but also for pain to the non-DRG group, which was a conventional stimulator. The control group was a Medtronic device at that time. Now, I always say to many people that the way we can tell a therapy is enduring is can it be reproduced. And so my original study is there to the left, the accurate study. I repeated that study with some colleagues in 13. And then many studies throughout the world has been done. When I actually made this slide, we had 570 patients in randomized prospective studies. Now the number is closer to 1,000. And all of those studies reproducing data with the average final visual analog scale being about 21.4. So less than 3, almost down to 2, with the, as you know, the World Health Organization criteria that severe pain is a 6 and pain should be under a 4 if possible. So that's quite a development. Where's the future going to take us? I think to new targets. Here's a look at L2 or L3, but L2, where the gray Raymond communicants comes in. And this is work looking at, can we control pain with DRG for axial back or discogenic pain? And certainly that's the what I would call the golden goose. We always try to control axial back pain. I work with my colleague, Dr. Jean-William Calaward over in Holland. I have privileges in the Netherlands. I went and did surgery with Dr. Calaward right before we saw the COVID pandemic. So I was able to get over there a few months before that occurred. And again, he published this work we did at L2. I think we're also going to see more and more work up in the cervical spine because the cervical DRG is extremely responsive for things like post-amputation syndrome of the upper extremity, trauma of the median nerve, trauma of the ulnar nerve, trauma of the radial nerve. So we're seeing more and more response from this type of therapy in that region. And again, the way we've made this much safer, we've been doing the cervical cases, which in the United States, this is labeled from T10 to S2, where the study was done. But in Europe and Australia and other places, it's labeled from the cervical to the sacral spine. Certainly this can be done off-label in the United States if the doctor feels it's appropriate. And you see here what this lead might look like. And what we're finding is that using general anesthesia with neuromonitoring makes this a very safe process. So we've been very successful. In fact, we've had great success with that target overall. For all the things I've said so far in this talk, and again, this is a very brief talk, so I'm going to give you this reference. This was published on February 22nd, 2018, in the journal Neuromodulation, and this is best practices for dorsal root ganglion stimulation. And again, I think you should get this article as a review reference because I think it will be helpful to your assessment. What's coming in the future? I want to spend the last few minutes talking about the future. We talked about L2 as a possible target for axial back pain, but here's a look at T12. And again, Dr. Ken Chapman and Dr. Kieran Patel in New York City have done several patients looking at T12. You see the lateral view there where the leads are dorsal to the vertebral bodies. And that's really worked quite well for people with that type of pain. I think where we're going, though, if you look at the animal models and the University of Wisconsin, Quinn Hogan and colleagues have published a few recent articles that DRG, which we always taught was for focal neuropathic pain, may be for joint pain. And I think you'll see us doing some feasibility work on this. For example, L2, L3, and S1, we have innervation of the hip. And I think, again, in the early work, we're seeing a signal that this may be very helpful in those who have persistent hip pain after replacement or those who aren't a candidate for replacement because of their health status, which we see from time to time. SI joint, here you see a lateral fusion. We're seeing a lot of people having pain post-lateral fusion. So the surgeon does a lateral fusion. They think it looks wonderful mechanically. Patient comes back to us and says, well, I'm actually worse. And the innervation there from S1 to S4. We also often will add T12 to this population. So that sacroiliac joint heavily innervated, as you know, from the lateral branches at L5, S1, S2, S3, S4, but also potentially T12. So another great target. Foot and ankle, L4 to S1. We're already seeing good relief for that type of innervation. You see to the right lower slide there what leads look like at L4, L5, S1. So I think this nociceptive work looks good. What we find in the animal model is, particularly in the paw, that there's marked reduction in inflammation in the inflammatory model with DRG. So we think there's an anti-inflammatory response going on at the dorsal ganglion in people that have nerve pain, but also in those with nociceptive pain in the joint. I published a recent article with Dr. Kinfa in Germany and Dr. Chakrabarthi, then we actually showed in the animal model a reduction in inflammation there as well. that's very important. Now, I recently did some work, which was published in Lancet, and I was one of the primary authors in that paper along with Dr. McKell and Dr. Levy. We actually looked at, something called closed loop or feedback loop, and we did a large prospective study, which isn't the topic today. But I will say, other than a closed loop system, the only thing that really doesn't have much variation with movement is dorsal ganglion stimulation, because while in the spinal cord you need closed loop, at the DRG, since there's very little CSF, we have a built-in closed loop system in that there's not much change in that system overall. I will say that there's a lot of work being done towards MRI, and I think that will be the next major advancement with DRG. Right now, it's conditionally approved for MRI under certain conditions, but there's work being done to make it MRI compatible in all patients, and I think that will be very important. Here's a look at a paper we published in Neuromodulation in 2020, looking at the MRI of any device in the space. So if you have any questions about MRI capabilities. What's the future going to hold for DRG? Virtual clinics. I did the world's first commercial programming a few weeks ago of a patient where we actually was set in our office and they were at their home and we were doing virtual programming of their device. And I think that remote programming is going to be very valuable for patients who have trouble traveling, those who live in remote areas. And I have some international patients who we can actually program their device while they're sitting at their home in a different country. Long-term outcome tracking, I think the cloud will help us track people's outcomes, the real-world registry, the paddle DRG. So for the neurosurgeon, orthopedic spine surgeons out there, if you have patients that you think would be a good candidate, many times anesthesiologists or physiatrists can't place the lead because there's some foraminal stenosis, there's some previous scar tissue from previous leads or back surgeries. And I think this will be a great option because this does work better than spinal cord stimulation in most patients. Not only for focal pain, which is where it was originally approved, but in some cases, nociceptive pain as well. And then we'll find better access and durability with new types of devices going forward. So I showed you that there was a big backlog of pain signal going out to a desire to make it into a very more specific signal. And now I'll tell you, our goal will be to balance that signal so that the pain fibers are actually well controlled. With that, I know it was a very brief talk, but that's our goal today. I look forward to more discussions with each of you going forward. Thank you very much. Well, I hope you enjoyed that. We're now going to take the first of our 2 breaks. We'll be resuming our lectures in about 4 minutes. Introduce our first sponsor of the evening.
Thank you, Dr. Deere. I'm Robin Young. I'm the publisher of Orthopedics This Week, and it is my pleasure to introduce Flexion Therapeutics, who's our first sponsor this evening. They are one of the leading innovators in the management of musculoskeletal pain, and they'll be describing ZILRETTA, which is a very interesting new product, and they'll be summarizing their study data, which is frankly pretty impressive. And there will be information about the company in the chat section. Please make use of it. And now the video. For those of you who would like to contact the company directly, again, look at the chat function. There's a link to the Flexion website. Again, ZILRETTA is a very interesting product, it's doing quite well. Dr. Deere, back to you in the lecture hall.
Our next presentation is from Dr. Beth Darnell, a good friend of mine from Stanford, who's an associate professor of anesthesiology and director of the Stanford Pain Relief Innovations Lab. She's here to talk to us about a study performed during the thick of COVID-19 on self-administered virtual reality for chronic low back pain. And I must say that every time I hear Beth speak, I learn a great deal. So Beth, it's an honor to introduce you, and I'll give the floor to Dr. Darnell.
Thank you, Dr. Deer. It's delightful to be here speaking about brief and digital skills-based interventions for pain relief. I just briefly want to show you my disclosures. This is my research funding, my leadership roles, and also books that I have published. So you're all well aware of the scope of the problem of pain in America, where up to 1 in 3 adults are living with ongoing pain of some type. And multiple government agencies have put forward that we need to be treating pain differently. We need to be treating pain comprehensively, integrating behavioral medicine into pain care pathways broadly. But we've really failed to implement on this wisdom. And to date, even 10 years later, it remains that pain is primarily treated as a biomedical problem, even though we know and have known for decades that pain is a biopsychosocial phenomenon, and that pain is even defined as such from the International Association for the Study of Pain. Pain is a product of the central nervous system, the brain, and the spinal cord. And for this reason, we can equip individuals with various skills and information that can regulate what is occurring in the central nervous system to help people gain control over their pain. And this is really the foundation for the biopsychosocial model of pain and also pain treatment. Now, the gold standard behavioral treatment for chronic pain is cognitive behavioral therapy for chronic pain. And over a course of 8, 10, 11 weeks, individuals learn various information and self-regulatory skills that help people better regulate their experience of pain, make healthy choices and decisions to self-manage pain and symptoms. And of course, this doesn't alter their medical diagnosis, but it helps them live better with the complex medical conditions that they have. And it's effective to the point that recently expert consensus panel at Lancet recommended that for people with chronic low back pain, cognitive behavioral therapy should be first line treatment, not the treatment of last resort as it's often applied. But the problem is that these behavioral medicine treatments, psychological treatments for chronic pain, self-management are largely inaccessible or difficult to access for these 100 million Americans who have ongoing pain. And we characterized these barriers to behavioral medicine in our 2016 National Needs Assessment. So solutions are needed to scale effective treatments to a population. So I'm going to be talking about 3 solutions in my talk, and the first is home-based VR. And so a team of us at Applied VR conducted the first home-based virtual reality study for individuals with chronic low back pain as well as fibromyalgia. And this was a national sample, and we enrolled 97 people, and they participated in a 21-day home-based VR program. It was a randomized controlled trial where people were either received audio treatment, effective skills-based treatment, but delivered in audio-only form, or they received immersive virtual reality. And this is just one example of what some of the virtual reality sessions look like. Now, of course, you're not seeing the 3D element that is immersive, but what you're seeing is that there's educational components, there are interoceptive awareness modules, and we're basically harnessing the power of immersive technology to help people acquire regulatory skill sets, such as calming the nervous system. And what we found was in this home-based 21-day program, we found substantial reductions in pain intensity and also pain interference with activity, sleep, stress, and also with mood. And so this gives you a schematic for the comparison, the comparative efficacy of the audio and the virtual reality. And this is for pain-related interference with activity over time. So you can see this difference, and this paper is published. This set the stage, these promising results set the stage for us to then test an 8-week self-administered at-home behavioral skills-based VR program for chronic low back pain. And so 8 weeks, people would participate with a virtual reality module every day. These are brief modules, about 5 to 7 minutes in length, but they participate on a daily basis, and the 8 weeks matches more closely to 8 weeks CBT. And so this is called Ease VRX, and you can see that this is, there's different themes for the week, different types of modules that involve, again, interoceptive awareness, self-regulatory skills, learning to calm the nervous system, distraction, etc. And this was a randomized controlled trial comparing immersive VR, therapeutic VR to sham VR, where people were in the control group, in the sham VR, were simply viewing 2D content like a TV set, and they were viewing nature scenes. And what we found was very high engagement for both groups, whether people got the sham or the therapeutic VR, engagement was high. And we found that people reported that the virtual reality home-based VR was easy to use, about as even easier than Gmail is what you can see on these participant ratings. And so let's talk about the efficacy. For 179 individuals in this study, we found meaningful reductions in pain intensity and superiority for people in virtual reality compared to the sham treatment. And this was, these data are for day 56, so post-treatment. We found similar results for pain interference with activity. So these being 2 primary outcomes. Now, this is a summary of our endpoints where you see differences for pain intensity, activity, sleep, mood, and stress, comparing therapeutic VR to sham VR. And you can see that there's superiority for the virtual reality. And this is exciting and suggests that home-based VR could be a nice solution, particularly for people who live in rural areas or who are not able to get to clinics to work with therapists. These data are not yet published, but what we're finding and soon to submit for review are our results showing that there is nice durability of effects. So even 3 months post-treatment, we're seeing sustained benefits for therapeutic VR compared to the sham VR treatment. So that's virtual reality, which is home-based and digital. The second solution that I want to discuss is a single session pain class that rapidly equips participants with actionable pain management strategies and skills. And this is called Empowered Relief. And we developed a single session compressed treatment out of recognition that very few people can come to and receive 8 weeks of cognitive behavioral therapy. But what can people receive? Well, what I discovered as a pain psychologist in clinic is that most people can attend 1 session while they can't all attend 8 sessions. And a lot of people don't want 8 sessions. So I created a single session compressed class, 2 hours long. And we tested whether a single session would be effective for symptom management. And so this was published in 2014. This was the first test, mixed etiology chronic pain in a clinical sample. And the first study just looked at pain catastrophizing, which is sort of an index of coping skills and pain-related distress. And we found substantial reductions 1 month later. So people just attended a single session, and 1 month later, they had sustained results that were that represented a large effect. And we also found benefits across a range of other outcomes. So this pilot study set the stage for us to conduct a large randomized controlled study that was funded by the NIH. This was a 3-arm RCT where we compared the single session Empowered Relief class to a single session health education class to 8 weeks of in-person CBT, the gold standard treatment. And we've been studying this for the past 6 years now. And just now our results have been accepted for publication. So I'm not going to present all of the data slides to you. Those data will be published shortly. But the message that I want to provide is that we found exciting efficacy for empowered relief 3 months post-treatment for all of these various multidimensional outcomes, very nice results for non-inferiority to 8 weeks CBT. And what these data are suggesting is that at least for a substantial fraction of patients, a single session class may be able to accomplish as much or close to as much as 8 weeks of in-person treatment. And we have now translated this into online delivery because in the age of COVID, very few people can receive in-person treatment anymore. So we've conducted an online study of empowered relief, randomized controlled study in 105 patients comparing online empowered relief to a waitlist control. And very similarly, we have been finding durability of effects at 3 months post-treatment. So this is really exciting when we think about what we need to do to accomplish treating the population of people, really scaling out our options. And a Zoom-based class, we have very nice signal for durability of effects there. It does need to be tested in a larger pragmatic study. Based on some of these exciting results, the US Department of Health and Human Services has recognized empowered relief as a promising and scalable treatment. And now at Stanford, we're conducting certification trainings for any clinician who wants to become a certified empowered relief instructor to embed this single session skills-based class into pain care pathways broadly. Cleveland Clinic has it embedded into their spine surgery pathways. And these are just some of the institutions that have empowered relief. We've certified 300 instructors to date. It is being delivered in 7 countries and it's available in 5 languages. And in just the last moment that I have, I want to talk about solution number 3. We have translated empowered relief, this brief skills-based class, into digital format specifically for people who are undergoing surgery. This is My Surgical Success, and people receive this treatment online. We wanted to understand whether a brief online behavioral treatment for pain might benefit people throughout the surgical pathway, sort of as an enhanced recovery after surgery option. We conducted a study in women undergoing surgery for breast cancer. This is a randomized controlled trial where women either received My Surgical Success or a digital health education control. We followed them after surgery to see if it would make a difference with their pain and their opioid use after surgery. And what we found was that the women who engaged with My Surgical Success, they required about a week less opioids after surgery compared to women who received the health education control. What's important about this is that we didn't direct women to use less medication. They simply had less pain after surgery or required less opioids. So this provided us with a really nice signal for efficacy. We're now studying this in different surgical populations, soon to report on a new randomized controlled trial in 83 patients undergoing orthopedic trauma surgery at Stanford University. This is led by Dr. Mesa Ziadny, and it's also being studied in multiple surgical types in Switzerland. And so with that, I just want to summarize and also thank all of the colleagues involved in this research, but 3 brief and digital options for pain and opioid reduction and improved symptom management: home-based virtual reality, empowered relief, a single session skills-based class that can be received in person or online, and My Surgical Success, a digital treatment for perioperative patients. And thank you so much for your time and attention, and be delighted to take questions.
Virtual reality and pain, truly innovational stuff. Dr. Darnell, that was amazing. Thank you so much. Next up, another close friend of mine who I've known for many years, back to his fellowship days at Cleveland Clinic. Now he's a leader in the field down at Oceaner Clinic in New Orleans. Dr. Maggot Gerges, Associate Professor and System Chair of the Interventional Pain Management Department at the University of Queensland, Oceaner Clinical School of Medicine. Thank you for joining us today, Maggot. I look forward to your talk. I think it's going to be spectacular.
Thank you, Dr. Deer, for inviting me for that great educational setting. And I'm here today to talk about utilizing high-frequency spinal cord stimulator for focal chronic post-surgical pain. My name is Magid Girgis, and I'm the System Chair of Interventional Pain for Ochsner Health System down in New Orleans. So I'll start my presentation talking about, the problem, which is the chronic post-surgical pain. In WHO and the International Association of Pain Study have recognized that particular kind of pain and defined it as the chronic pain happening after a surgery or a trauma that extended over 3 months. And for this particular study that we're going to talk about today, I'm going to focus only on the neuropathic post-surgical pain. So neuropathic chronic post-surgical pain. And as you can see here, there's multiple surgeries would lead to the incidence of chronic post-surgical pain. And particularly for neuropathic, we're going to be looking at the focal mononeuropathy that is limited to 1 or 2 dermatomes that is pretty much related to the surgery or the trauma. There's a high incidence of that pain happening after certain surgeries, go all the way from 10 to 50% of patients being really high post-mastectomy or amputation. We can see that also after cardiac surgery and hernia repair. A little bit lower in cases of hip replacement and has significant incident when it happens in the knee or the ankle, but thank God the incident is much lower than other surgeries. As you know, that we do about 9 million knees in the US. So we expect that particularly to be somewhere in the vicinity of maybe 10 to 12% after knee replacement. Now, this trial have been designed as a single arm prospective trial that have taken an exclusion and inclusion criteria depending on neuropathic pain happening after surgery. So as we discussed that diagnosis, we looked at all those surgeries and we have identified candidates who would have a VAS pain score of 5 out of 10 or above, and would score on a questionnaire specific for neuropathic pain called the DN4 or Dolora Neuropathica 4, and they would score above 4, and that would characterize that particular pain to being a neuropathic pain. Our exclusion criteria was patient who had previous experience with spinal cord stimulator, or people who had chronic back or trunk pain related to post-laminectomy or failed back syndrome. So we actually, took the post-laminectomy syndrome out. Now, we identified success in this study as 40% relief after the trial, which is a little bit less than the 50% relief that we used as in the chronic pain arena for considering a spinal cord stimulator a successful stimulation. And particularly that was at the beginning of the trial, but I will show you other results that showed actually that the success of the trial was even more significant and showed better results. 40% still acceptable, as this is a little bit above the minimal meaningful capacity to treat, which is usually about 30%. Now, the thought was to utilize particularly high frequency based on multiple previous anecdotal either case report or retrospective trial that showed some success of regular conventional spinal cord stimulation. But as you know, in particular areas, it's very hard to induce the paresthesia or the paresthesia sensation, especially for post-mastectomy or post-hernia pain, as that becomes uncomfortable sensation, specifically if it involved the chest or the abdomen. So conventional stem had its limitation, specifically for post-surgical pain. And while it did show success, it was not as evident success that would have pushed on designing a bigger kind of like conventional stimulation trial. And that why the thought came about utilizing high frequency or 10 kilohertz here, because it is a, paresthesia independent kind of treatment. And that might be one of the reasons why conventional stem have failed in particularly multiple location for post-surgical pain. Now, the other things have been utilized in the past for post-surgical pain, including, conservative treatment, medical management, and peripheral nerve stimulation was one of the other things that have also trialed in the past. But due to a lot of reasons for peripheral nerve stimulation, as far as, the feasibility of finding the nerve or the trauma that happened and lead migration that happened a lot with peripheral nerve stimulation, there was not solid trials done for PNS in the past before this trial had been designed. Now, looking forward right now, I've seen a lot of peripheral nerve stimulation trials coming for post-surgical pain. And I think that would continue to evolve and show up in the literature. So as you can see from this, there was specification for any post-surgical pain. So that included post-hernia surgery, post-mastectomy surgery, post-knee surgery, post-ankle surgery. And if you're familiar with particular ankle pain, you know that this was one of the toughest areas where we could cover with conventional stimulation in the past. And a lot of physicians would always say it's much easier to cover the trunk, lower extremity, sometimes the back, than actually being able to cover very low towards the foot or the ankle level. And that's one other things that I think, success here of high frequency stimulation might be very evident, because it does not particularly depend on where the dermatomal pain distribution. It's an anatomical placement of the spinal cord stimulation. So the placement, while still anatomical, it was dictated by the presence of the pain. So that meaning that in some situation where if the pain was in the upper extremity, we utilized the C2 to C6 area to put our leads. If it was in the trunk and lower extremity, from T8 to T11 was the specification for particularly trunk and lower extremity, and that covered the ankle very well. I can say from my trials, from my subjects in the subjects that we recruited in our site, there was at least 4 of those subjects that had ankle surgery. And a lot of those subjects we figured out that we're actually stimulating their sweet spot was not T9, 10, it was about T10, 11. And some of them, it was like mid of T11. So that's really covering the foot, even with high frequency stimulation, made us think about putting the lead a little bit lower from the T8, T11 distribution. And a lot of even in my commercial side patient right now have like ankle pain, I would put my leads between T9 and T12. Now for abdominal and, like chest, post-surgical abdominal or post-mastectomy pain, we kind of use the guide for the dermatomal distribution of pain, and they made sure that the lead would cover at least 2 levels above where that dermatomal distribution is. And that has been very successful. And I can say that maybe after that trial, that this trial was started maybe about 4.5 years back. So after that trial, that gave a very good idea about placement of high frequency stimulation to different anatomical site. And while everybody was thinking about specific point of a specific sweet spot in the spine, we figure out that sometimes that sweet spot change, and that would cover the pain much better. So the results of this trial showed up. So 34 subjects were actually, recruited based on from baseline. About 27 were implanted, and out of those, about 23 were followed for 12 months. So if you can see here, the responder rate, which we here define after the results of the study. So for inclusion criteria, it was about 40%, but actually what we figured out after the results of the study came out, we took the responder rate of above 50% of pain relief. And you can see here over 12 months stayed at 87%, which is very successful compared to other trials utilizing conventional stem in the past. And I would say it's really good to see 87% relief Although right now in the spinal cord stimulator arena for treatment of other even chronic pain condition, everybody's expecting success of 80 to 90%. Sustainability to 12 months is really good, and it's a good thing to see that at least that particular relief is staying above 80% for 12 months. We saw a VOS reduction score, and you can see it dropped significantly to 1.4 after 12 months. We also seen a drop in pain disability index over 12 months, and minimal clinical important difference was between 8.5 to 9.5, and at 12 months there was about 29.6 point reduction. That's 3 times the minimal clinical important difference, which showed a lot of change in functionality and capability of our subject to perform a lot of activities. I can share one of the most successful stories in that trial. He had a manager of a big department store that was really devastated, was out of work because of pain after an ankle surgery. And that person, right after our implant, was able to return back to his job, was able actually over the year to get promoted multiple times. And one of the best time, when you treat those patients is that while I stopped following that patient after 12 months because he moved to another state, 2 years back into the trial, COVID happened, and he actually sent our hospital a big donation of N95 masks, thanking us for helping him over 24 months. And that was one of the best stories that we got to show success of treatment of such a very bad disease to treat. He was out of work for about 3.5 years. So I'd say, in conclusion, high frequency stimulation is really showed a lot of success in treating focal neuropathic post-surgical pain. It is much simpler than other therapy. It is much superior than conservative therapy. It still depends on anatomical lead placement with multiple variation depending where the pain is. It does not require intra-op paresthesia mapping. If you're familiar with high frequency stimulation, there's no time lost in the trial or the implant to do any kind of paresthesia mapping. So it all depends on exactly where the pain is. You put the leads anatomically in, then you expect hopefully that the trial will be successful and have that significant relief that we've seen over 80%. It showed significant relief, and it showed significant drop in disability. And we're hopeful that this particular single arm trial would lead to more trials utilizing this therapy for treatment of multiple varieties of chronic post-surgical pain. And hopefully that would be the next step after publishing such a trial. I'd like to thank you all for your attention, and I think after that, we're going to be open for questions. Thank you.
Thanks for your presentation, Megan. Next, we have Dr. Scott Lemke, Assistant Professor of Anesthesiology and Biomedical Engineering at the University of Michigan. His presentation tonight is spinal cord stimulation for pain. Scott, I look forward to hearing your overview and see if we have any cross thoughts on my previous lecture. So the floor is yours, my friend.
I'd like to thank Dr. Deer for the introduction. As he said, my name is Scott Lemke, and I'm Assistant Professor in the Departments of Biomedical Engineering and Anesthesiology at the University of Michigan. And I'm going to talk today about some of the work we've been doing developing patient-specific computer models to study the neural response to spinal cord stimulation for pain. And before I do that, I'd like to thank Palomi and Dr. Young for the invitation. It's a pleasure and honor to be here. So here's my disclosures. So our lab is called the Neuromodulation Lab, and our primary work focuses on spinal cord and dorsal root ganglion stimulation for pain. And we really want to find ways to study these therapies in the patients that are getting these therapies as part of their clinical care. And so we do a lot of clinical testing, but then we also do a lot of computational modeling. And the advantages of these computer models is that we can When we look at testing human patients, we're really limited in the methods that we can employ. And so the computer models can help us understand the stimulation better, and they provide a systematic, well-controlled environment where we can look at a number of parameters and how they will affect the neural response to the stimulation. So you've heard a lot already about a lot of the exciting developments in the area of spinal cord stimulation and other neuromodulation therapies for chronic pain. But when we look at spinal cord stimulation, we have an array of electrodes that's implanted in the epidural space, typically or often at the lower thoracic levels to treat things like low back pain and leg pain. And these electrodes are connected to an implanted stimulator, typically that's implanted in the posterior hip area. And what we're trying to do is we're applying these short duration electrical pulses, and we want to excite different parts of the spinal cord. And the goal, at least with traditional spinal cord stimulation, has been to generate paresthesias. And what we want to do is adjust the stimulation so that we're targeting the right part of the spinal cord to get these paresthesias to overlap with the patient's painful areas. And then what happens is we can exploit the circuitry that exists within the spinal cord to help relieve pain. And so how can we do this? How can we adjust the stimulation to hit the desired areas of the spinal cord? Well, if we look at the pulses themselves, we can adjust things like the amplitude, we can adjust the duration or the pulse width. We can also adjust the frequency or how many pulses we apply per second. And then finally, if we look, we also have a number of electrodes that we have to select and use to apply the stimulation. So here's an example of 2 electrode arrays where we have 8 electrodes on each for 16 total. We're not going to use all of those electrodes to apply the stimulation. And so what we have to figure out is the best combination of negative and positive or cathode and anodes to shape the electric field to target the desired area of the spinal cord. And you can see here's examples from actually one of our patients where they picked multiple settings running to target different parts of the spinal cord. And again, what we want to do is hit the right spot so we get this nice pain, what we call pain paresthesia overlap. And if we're able to get that to a sufficient degree, then there's empirical evidence would suggest that the patient is likely to respond to the stimulation. So spinal cord stimulation is an amazingly powerful therapy, but it's not perfect. So we're always trying to find ways to make it better. And just like with any therapy, there's 3 main approaches we can take to study the therapy. We can look at computational models or theoretical studies. We can use animal models, or we can perform clinical studies. What I'm going to talk about today is some work using these computer models, but I'm also going to give you an idea of how we can use these computer models to improve clinical implementation of these technologies. So computer models for studying spinal cord stimulation actually have a rich history dating all the way back to the 1980s with Sin and Coburn, but the work really took off in the 90s with Jan Holsheimer's group in the Netherlands. And unfortunately, Jan Holsheimer recently passed away. But his seminal work taught us a tremendous amount about how this therapy might work scientifically, but also we learned a great deal about how we can improve the design of the technology as well as pick the best stimulation parameters. But those models I showed on the previous slide, they're what we'd call canonical or generalized models. They don't account for the kind of variability in anatomy and lead placement that we see in patients. So we've actually been doing this work developing patient-specific models. And this is work we published recently in neuromodulation. And what we can do is we can take the preoperative MRI to get a good 3D description of the patient's anatomy. Then we can take a postoperative CT. Often these metal electrodes, their MRI is contraindicated, although the MRI compatibility of these systems has improved dramatically over the last several years. But we can take a post-op CT to localize the spine as well as the implanted electrodes. And then what we can do is co-register these 2 data sets together to generate what's called a patient-specific finite element model. And we can use that model to calculate the voltages that would be generated within the spinal cord during stimulation. So we use that finite element model to calculate these voltages, but what we can then do is develop models of the axons and the neurons within the spinal cord itself. So you can see an example of a single axon on the superficial dorsal aspect of the spinal cord, and then it's running rostrocaudally. And what we do is then apply these voltages to that axon. So you can see here, we superimpose the voltages along the axon, and these voltages are really going to determine how or if this axon is going to respond to stimulation. So you see at top here, we're applying this kind of 50 hertz classic SCS pulse or stimulation waveforms. And then what we have below are each row here is the time-dependent membrane potential at different locations along the axon. And so if you look at the red trace here in particular, that is the location closest to this stimulating electrode. You can see when we apply the pulse, we generate an action potential that then travels both caudally down the axon as well as rostrally towards the brain. So what we wanted to do was see if this patient-specific modeling approach could be useful in predicting what we would observe in the clinic. And so what we did is we measured what's called sensory threshold in these patients, where we're looking at how high does the stimulation amplitude have to be for them to sense the stimulation or to get these paresthesias. And not just look at one value, but look at what happens as we increase the pulse width. So what happens is as you make these pulse widths longer and longer or wider and wider, the amplitude necessary to generate these paresthesias go down. So we measured these paresthesia or sensory thresholds in our patient that we had built this model. If you look at black, these are the measurements that we took in the clinic. And you can see we get this exponential decrease as we increase the pulse width. Then what we did is we wanted to use our patient-specific model to see if it could also, if it could get accurate predictions of this sensory threshold. And you can see if you look at in the dashed gray line here that the patient-specific model did an excellent job predicting this sensory threshold at each of the pulse widths that we tested. And then finally, we looked at a canonical type model, which is this idealized model that doesn't include the patient-specific anatomy or electrode locations. And you can see here that it did not do nearly as good of a job predicting these sensory thresholds. So this is just a proof of concept study that we did in one patient, but can this kind of approach be useful clinically? And so to hopefully convince you, I'm going to present some data from a large industry-sponsored trial where they studied two arms that had approximately 200 patients in each arm. In the first arm, these patients were getting spinal cord stimulation with a older or previous generation system that did not have these patient-specific modeling capabilities. And in the second arm, approximately another 200 patients was treated with a newer system that had the ability to implement these patient-specific models. Now, it wasn't to the level of detail that I described in our work, but the commercial system was able to account for the patient-specific electrode locations. And then what they could do is pick a location in the spinal cord that they would like to focus the stimulation. And then the system would use these computer models to split the current or fractionate the current through the different electrodes to get that desired stimulation focus. And so they analyzed a number of things, but if you look here, here's the outcomes for responder rates with regards to overall pain, leg pain, and back pain. And in the red bars, this is the patients who were treated with the previous generation system that did not have these modeling capabilities, where in the blue bars show the patients that were treated with this newer generation system that was able to do this patient-specific modeling. And if you look, you can see there's statistically significant improvements in overall leg and back pain in the newer generation versus the older generation. So this gives you evidence that these kind of computer models can be very useful in improving the clinical implementation of these technologies. And then finally, just ending with thinking about clinical decision support some more. If you look over here, we have on the right, we have very sophisticated lead designs now, where we have anywhere from 8 to 32 electrodes, and there's even systems being developed that have up to 64 electrodes. So we have to somehow pick the right combinations of electrodes to apply the stimulation. In addition to that, we also have a number of waveforms. For many years, we were only using this type of conventional, traditional type 50 hertz stimulation, but now we have newer forms that some of them you've heard about tonight, with the goal of helping improve outcomes. And one thing I should also mention is that these newer forms are often operated in a paresthesia-free manner. So when we look at traditional stimulation, we've used that pain-paresthesia overlap. We use the paresthesia as a surrogate signal to help with the programming. So that pain relief can often take time. It can take minutes or hours or even days, depending on the type of stimulation. But with the paresthesias, you would feel the paresthesias instantaneously. And so what you could do is use these paresthesias as a surrogate to try a large number of parameter sets within a short period of time, such as a single clinical visit. Now, with these newer forms that don't have this surrogate paresthesia signal, it can be quite challenging to determine the right settings to use in the patients. And sometimes you try one setting and you have to wait a day before you can try a second setting. And if you look at the number of permutations or parameter sets that you could potentially consider in these systems, it's greater than 10 to the 16th. And so obviously you can't explore this many options within a single clinical visit. And so computational models offer a nice tool to efficiently explore a large percent of this parameter space. And potentially, specifically, they can help if you implement them in a patient-specific manner where you can adopt or account for variability in anatomy as well as electrode locations. Finally, just like to thank all the wonderful people I've been fortunate to work with over the last several years, as well as our funding support. And again, I'd like to thank the organizers and Dr. Deere. It's been a pleasure and honor, and I wish you all the best. Thank you.
Thank you very much, Scott. We are now going to take the second of our 2 breaks. We'll be resuming our lectures in about 4 minutes. It will take us to the lecture hall to hear from our next sponsor.
Hi, it's Robin Young again. I'm the publisher of Orthopedics This Week. I wanted to take a moment and alert everyone in the audience about 3 programs that are coming up. The first one is The Pitch. Our second episode is June 10th. And I don't know how many of you know, but I spent roughly 30 years as a Wall Street analyst, and my role on Wall Street was to find interesting new little technology companies. And it was frankly one of the most enjoyable things I did. I created The Pitch to kind of bring what I consider to be the fun of science, the drama of medicine, and really the passion of an entrepreneur into a program, the kind of thing I experienced as a Wall Street analyst, put it into a program and let you, the audience, experience that too. And we call it The Pitch, and we invite entrepreneurs from young tech companies make a pitch. And we have a panel of some very experienced investors, actually, including engineers, surgeons, and one fellow from Wall Street and a strategic, ask questions. It's a really interesting program. Make sure you register for it. Again, that's on June 10th. And I'm not going to tell you who the 3 presenters are. That's a surprise, but I guarantee you they're very interesting. The other thing I wanted to call attention to, we have a June 17th sports medicine program, but there are 3 presenters in particular that are presenting for the first time some pretty extraordinary information. The first one is Julian Bales. He's one of the leading researchers in the area of concussion. He's come up with a real fascinating way of preventing concussions using a neck collar. And this will be really the first time that I think the audience is going to be able to hear about that. The other one is Sid Padia. He's an interventional radiologist, and I guarantee you, you have not seen this approach to treating moderate to severe knee osteoarthritis. It's a brand new approach. He just finished his study. The data is frankly shockingly good. You got to hear that presentation. I kid you not, this may be the best presentation you hear in a while. And the third one is Dr. Malanga, Jerry Malanga. You know, regenerative medicine has been around for a while. The big criticism is there's no data. Well, Jerry put together a registry of more than 10,000 patients. It's growing rapidly. He is presenting the data for the first time at this meeting. So by all means, make sure you register for the advanced topics in sports medicine. You're going to hear stuff here you have not heard before. It's going to be probably our best meeting of the year. And then finally, I'd be remiss if I didn't remind everybody, don't miss the May 26th course on minimally invasive alternatives to open orthopedic procedures. That seems like a general topic, but frankly, that's the main trend in orthopedics, is moving to MIS, ASCs, and it opens up, in terms of practice building, it opens up a new patient profile, and you'll hear more about that at this meeting, a new patient profile that can add to your practice. So I hope you guys make a point to register. Again, register for the May 26th meeting, register for the sports medicine meeting on June 17th, and by all means, you know, be part of the audience on the pitch. You get to vote on each presenter as well. So thank you very much. And back to Dr. Deer.
Our next presentation is from Dr. Scott Kelly, who is the Chief Medical Officer of Flexion Therapeutics, here to talk about the newest innovation in pain management, FX301. So thanks for being with us, Scott. Looking forward to hearing your thoughts on this issue.
Thank you, Dr. Deer, and thank you to Robin Young and Orthopedics this week for this opportunity to share an effort at innovation in pain management. On behalf of my colleagues at Flexion Therapeutics, I'm pleased to share with you the development of a novel agent and formulation to enable a long-acting analgesic nerve block. The goal of enhancing postoperative pain management by an analgesic block, I think, is part of our efforts to reduce, in general, the use of opioids following orthopedic surgical procedures. Achieving a potent and durable regional analgesic effect while maintaining motor function is what's unique about this program. In the current state, anesthesiologists such as myself utilize non-selective local anesthetics, for example, bupivacaine and ropivacaine, to provide proximal nerve blocks, which are complicated by profound motor weakness of that involved extremity. With more advanced techniques, distal and sensory selective nerve blocks can be placed that minimize motor weakness. But we're still limited in duration of our current agents to 24, some people say perhaps 48, and on rare occasions, an effective block for 72 hours. In the future state, providing a proximal nerve block with a sensory selective compound and extended duration is really the goal of our current development program. We're doing this by utilizing advanced insights into pharmacology. Sodium channel 1.7, that I'll abbreviate as NaV 1.7, these antagonists target sensory-specific, selective, voltage-gated sodium channels. By locally delivering a NaV 1.7 antagonist directly proximal to the or adjacent to the nerve using a sustained release technology formulation could achieve this prolonged postoperative analgesia. The graphic here shows that these sodium channel blockers, particularly in proximity to the spinal cord, have the opportunity to engage nociceptive, the pain-carrying fibers, right before entry into the spinal cord. So why did NaV 1.7, become a pain target? If we turn the history chapter back just a couple decades, in the mid-2000s, the use of genetic techniques and identification really enlightened the understanding of this specific sodium channel. First, there's an inherited condition called inherited erythromelalgia, IEM, which a specific mutation in a gene, SCN9A, leads to this condition. These patients get incredible pain sensation with innocuous stimulation. For example, taking off a sweater is an incredible painful event for these patients. It turns out these patients have a hyperactive NaV 1.7 system. The other big breakthrough came serendipitously. A Pakistani child was noted to be doing kind of show performance in which he would damage himself for tourists with knives or walking across burning coals, yet never complained of pain. At the same time, a scientist in London identified or created a pain-insensitive mouse by doing a knockout to the gene coding for NaV 1.7. Taken together, yet again, the same gene, SCN9A, found to be the specific gene coding for NaV 1.7, is this underlying culprit in congenital insensitivity to pain. So these two factors from different parts of the world identify that NaV 1.7 is absolutely required for humans to feel sorts of pain. Well, if you have to have it to feel pain, what happens if you take it out? And that's really been an effort for drug development for the last decade. In fact, there's been extensive interest and efforts at developing NaV 1.7 antagonists. This is just a listing of some of the pharmaceutical companies that have really been trying to develop this agonist or antagonist for systemic drug delivery, typically oral or topical formulations to treat a variety of neuropathic pain conditions, trigeminal neuralgia, postherpetic neuralgia, or cancer pain. None of them have succeeded to date. And why is that? One of the things is that there's dose-limiting toxicity. To get enough drug to have the effect, you start seeing unintended side effects. This is common for all sodium channel blockers. Remember, as an anesthesiologist or in your own practice using local anesthetics, we always know about the maximum dose of bupivacaine because we don't want to trip into systemic side effects, whether that be a seizure or cardiac arrest. NAV 1.7 has particular side effects, particularly in the CNS. What we did was really come up with a new program. We call it FX301. Most importantly, I need to inform all of you that this is a program under investigation as an agent for peripheral nerve block. This has not been evaluated or approved for use by the FDA. But our hypothesis is that selective inhibition of this channel via peripheral nerve block technique could provide robust analgesia and not impair motor function. What's unique about FX301 is it's a micellar formulation of funapide. Funapide is a sodium NAV 1.7 inhibitor. And what we've done in this formulation, it's a thermosensitive gel that captures the molecule and then releases it slowly over time. Remember, it's going to be a nerve block. So it will be administered via injection near a peripheral nerve, the same way I would do an anesthetic nerve block. It goes in as a liquid state and then forms a viscous, pliable gel at body temperature. The local release over a sustained period of time is what should generate the anti-nociceptive effect in those specific sensory nerves. This cartoon here shows this thermosetting hydrogel, where essentially on the left-hand part of the graphic, self-assembly of this PLGA, PEG-PLGA combination traps the molecule inside of it. It then, between the different temperatures, 25 degrees and 37 degrees body temperature, it goes from liquid to a gel-like. What this means in reality, it's very easy to inject at room temperature. It then forms a viscous, pliable gel at body temperature following administration. It has the consistency after gelling of something like Vaseline, so petroleum jelly. It's capable of releasing drug over the next 3 to 7 days, which allows maintaining a high concentration at the target nerve. The PLGA technology, this hydrogel, it's biodegradable, it's resorbable, it has a long history, and the core molecule is actually water. Therefore, it's generally well tolerated. And our preclinical models support that as well. I have a graphic here I'd like to share, or a video here that I'd like to share. This shows an example of trying to inject or injection of FX301 into a mini pig model. What you see first is the continuous flow is the injection of the liquid form of the compound. And like all of you have had to wait for a nerve block to set up, we're going to wait here just about 30 seconds. What we see first is continuous liquid injection as the nerve block is being injected. But what's unique about this video is we will capture that thermosetting gel formulation. You can already start to see some of the strands getting a little more intense. And if time will serve me well, we will see a state transition that will capture the eyes of all of us. We're seeing a little thicker strands there. We're starting to see even more. And now we're seeing a real change in that transition, that composition. So that's really the injection continuing to go around the nerve, getting a little bit thicker following injection. And there, that's the final transformation. So I think this will be interesting for our regional anesthesiologists to use because they will be able to see where that gel has been deposited. But to advance this to, really a full innovation means getting it into the clinic. To get it into the clinic, we have to demonstrate some preclinical safety and efficacy assessments for the FDA. The preclinical model here, the lead author on this was Dr. Becca Center from Flexion Therapeutics. This was a podium presentation at last year's American Society of Anesthesiologists meeting. We took 3 groups of animals and did a sciatic nerve block either with vehicle, with our compound FX301, or with a well-respected local anesthetic, liposomal bupivacaine, did a sciatic nerve block. We then induced surgical pain in these animals with an anterior tibial incision. For the next 72 hours, we did a number of assessments, both for pain assessments, the ability for the animals to walk, and finally, we did local pharmacology so we could understand if we had enabled that sustained release. Most importantly, we had demonstration that FX301 reduced the evoked pain in this postoperative pain model. Von Frey testing is a provocative testing where we can measure the analgesic effect. It essentially involves using small wires and putting enough pressure on the wire to make the animal have a withdrawal response. If I call your attention to the day 1 measurement at 1 hour after surgery, the purple bar represents the animals that had a placebo nerve block. It didn't take hardly any pressure on the wire to cause a painful response, elicit a painful response from the animal. In contrast, those animals that are getting either FX301 or liposomal bupivacaine took a lot more force to generate that painful response. Now I want to go over to day 2, the 36-hour time point. 36 hours after the injection, it was only FX301 that distinguished having the greatest degree of analgesic effect compared to both placebo as well as liposomal bupivacaine. Besides this kind of evoked response, the other thing we did, veterinarians are able to assess pain-related behaviors in the animals. And once again, we see that in contrast to vehicle and even to liposomal bupivacaine, those animals treated with FX301 had a lower global pain-related behavioral score, suggesting continued analgesic benefit. One of my challenges, and in the pain field as in general, and I think Dr. Deer may be able to comment on this, is the idea that animals don't talk. I wish I had a 0 to 10 score from these animals, but we have to use these indirect measures. That's why it's so important to validate these preclinical models in human patients. In addition to this idea of pain behavior, I mentioned earlier the importance of preserving motor function. We did that with an interesting technique of using a camera over these animals in their open pens. For the 3 groups, vehicle, bupivacaine, FX301, what we see here is kind of a capture of the digital recording of those animals. Baseline is before the block and before surgery. And then we have on the right-hand panel, 1/2 hour after the block. Clearly, the vehicle is still kind of running around like normal, as is essentially the animal at the bottom, the FX301. But look at the one in the middle. Barely makes it 1 lap around the pen and probably is limping and dragging the leg at the same time. When we quantify this with total walking distance, we get these results here, where particularly if you look at the 2-hour time point, there's a reduction in the total walking distance seen both in FX301 or FX201. We don't know if this is some benefit of analgesic effect, but look at 24 hours. The animals receiving liposomal bupivacaine still have a reduced walking distance compared to placebo or to FX301. We believe this is strong evidence that it's not reducing total or having a substantial motor effect. Finally, we did local and systemic PK concentrations. What this is basically saying, and if I point to the data on the left, that this thermosetting gel is having sustained, almost constant release from the vehicle over 72 hours. This is very good evidence that we will see an ability to keep high tissue concentrations. We measured 1 time point after the injection. We did a local muscle biopsy near where the nerve block had been placed, had an astronomically high number. We believe the formulation does enable high concentration needed to have the analgesic effect. And we're making progress. Earlier this year, on March 1st, we announced that the FDA had cleared an investigational new drug application for FX301, this novel formulation. More importantly, I'm pleased to announce that on March 31st, we dosed the first patient treated with FX301 in a phase 1B trial for management of postoperative pain. This is a proof of concept that will evaluate safety and tolerability of this compound administered as a peripheral analgesic nerve block in patients undergoing bunionectomy. The good news is for an acute pain study, we hope to have initial data later this year. This is a schematic of the study design. Essentially, we know bunionectomy is a painful surgical procedure. It's a validated testing ground for looking at a variety of analgesic strategies. What we're doing here is looking at different drug levels of FX301 and different volumes in the nerve block to see if there's an analgesic effect. This will be done where we have patients that stay over in a clinical site for 5 days. It allows us to evaluate the primary endpoint of safety and tolerability through adverse events, collect PK measurements, and then start looking at detailed pain assessments, including more continuous numeric rating scales from 0 to 10, as well as the percent of patients that are pain-free, time to first opioid use, and total consumption of postoperative opioid use. By having a placebo group in this study, it allows us to say, is there true efficacy of the FX301 agent? So again, in conclusion, FX301, I do believe, is an advance and innovation in pain management. Based upon preclinical demonstration of analgesic effect with increased withdrawal threshold and reduction in behavioral score, as well as a motor sparing showing absence of significant change in total walking distance relative to placebo and liposomal bupivacaine, indicate sustained motor sparing analgesic effect. The local tissue concentrations are high 72 hours after injection, supporting the idea that it will have a sustained benefit. The results to date support continued development of FX301, a long-acting motor-sparing agent for peripheral nerve block to manage postoperative pain. We're expecting initial clinical data from phase 1B, the bunionectomy study, late this year, and that would guide future development. Thank you for your time, and I look forward to questions.
Excellent.
Thank you, Scott, for this great presentation. Our last presentation tonight before our live Q&A session will be from Senior Associate at MCR and current concepts of pain management reimbursement. I think it's an important topic because we need patient access, and reimbursement is so important. So from the MCRA team, the floor is yours.
Good evening, everyone. Thank you so much for joining us. My name is Jasmine Pickett. I am the Senior Case and Coding Reimbursement Specialist here at MCRA. Today, I'm going to be talking to you all about innovations in pain management, specifically as it relates to neuromodulation, which is going to be an alternative pain management method. All right, so let's continue. We are going to cover coverage, coding, and payment. We're going to be talking about neuromodulation as it relates to peripheral nerve stimulation, and we're going to cover the basics for, again, coding, coverage, coding, and payment. So you all may be wondering why we have chosen to discuss this topic. As I'm sure many of you are aware, that there is a opioid crisis in our country. So payers and physicians are always consistently looking for alternatives for prescription pain medications. You know, we have to find other ways to be able to treat people that don't, you know, end up with people being addicted to opioid drugs. So we'll go into a little bit about neuromodulation. So before I get into the coverage of neuromodulation, for those of you that may not be familiar with it, let's kind of talk about neuromodulation for a little bit and what it is. Neuromodulation overall is a therapy that is continuing to undergo refinement and research as it relates to its different effects and applications. Electrical neurostimulation implants are believed to activate the natural biological responses, such as nerve transmissions and release of the body's own pain-reducing substances in the neural circuits receiving stimulation. Central to the operation of electrical implants are thin insulated leads that are going to be placed beneath the skin that are tipped by electrical contacts. The contacts are no bigger than a grain of rice and are positioned beside the nerve or the specific nerves that influence the condition that is actually being treated. Pulses of mild electrical currents are sent down the leads to the nerves. We then have a battery-operated generator that is about the size of a stopwatch that powers the pulses. If a patient responds well to several days of treatment, this sort of pulse generator will be implanted as well. After the system has been implanted, the clinician will then work with the patient to program the stimulation pattern, which can be adjusted over time. Typically at home, patients can use some sort of handheld controller to turn the switch on or off. And that's pretty much how it works. And it helps for chronic pain management. So looking at this from a coverage standpoint, Medicare has a national coverage determination, and they have made the decision that they will potentially, cover this particular service as it relates to peripheral nerve stimulators for chronic intractable pain. So what you're seeing on the screen is a snippet from the Medicare NDC, which shows that they will cover this for chronic pain. Now, in terms of private payers, we're going to be using Blue Cross Blue Shield as an example. Different payers tend to have different policies, but typically from a private payer standpoint, what they are going to be looking at in terms of the technology evaluation criteria are these 5 things. They're looking to see if the technology must have made final approval from the appropriate governmental regulatory bodies. The scientific evidence must permit conclusions concerning the effect of the technology on health outcomes. The technology must improve the net health outcomes. The technology must be as beneficial as any established alternative. And the improvement must be attainable outside the investigational setting. So these are pretty much the 5 areas. Now, if we kind of look at some of the bigger, keep continuing looking at the big players, Aetna, Anthem, Blue Cross, Cigna, Humana, for the peripheral nerve stimulation. Aetna is the only one that actually has a policy where this will actually be covered. Cigna and Humana have made the determination that they're not going to cover it. And Anthem and United Health, they have silent policies, which means that it's going to be strictly based on medical necessity on a case-by-case basis. So let's take a little bit deeper dive into that. So here's Aetna. So from the previous slide, Aetna was the one that did have coverage for this. But again, it is covered for chronic intractable pain. So if a person is experiencing, chronic pain or intractable neurogenic pain, Aetna will potentially cover the service. Now, Cigna, here's an example from Cigna's policy, a Cigna policy, where they are not covering it as they consider peripheral nerve stimulation to be experimental or investigational. We have United Healthcare. They were one of the payers that had a silent policy. So under their policy, they have this whole list of essentially nerve stimulation techniques that, they're going to base it off of medical necessity, case by case basis, depending on the patient. So we can take a look at some of the coding for the peripheral nerve stimulation. The codes here are 64555 for the percutaneous implantation of a neural stimulator electrode array, the peripheral nerve. This screen is showing us the difference of payment in the outpatient setting as well as the ASC setting. So as we can see here for the 64555, it aligns with the APC 5462 with the status indicator of J1, and the Medicare estimated 2021 national payment amount is about $6,160. In the ASC setting, it maps to a J8 payment indicator, coming in at a little bit less at $4,783. The J8 indicator pretty much indicates that it's a device-intensive procedure. And so they take that into consideration. So the payment is going to be a little bit less in the ASC side. With 64590, this is going to be the insertion or replacement of the peripheral or gastric neural stimulator pulse generator. Kind of what I was explaining earlier, that the battery operated generator, which is about the size of a stopwatch, this is the insertion for something like that. As we can see, it is also aligned to APC 5464, status indicator J1, and we can see here it's paid actually really, really well at $20,479, as opposed to in the ASC setting where it's a little bit lower at 15, a little bit above 15,000. Continuing on, we have revisions or removals. I'm sure, when things are being, put in, it may not always go right the first time. So in the event that revision or removal has to take place, it is actually paid significantly less. Let me go back. I apologize. It's actually paid significantly less at a little over $3,200, and in the ASC setting, a little over $1,500. And the same thing is going to be for the receiver as well. We do put unlisted codes on here because the unlisted codes are an option, but please be aware that unlisted codes do not have any type of payment automatically assigned to them from from an APC or ASC standpoint. Those are going to be pretty much payer specific if that's going to be paid. To continue, we have also the codes for the electronic analysis of the implanted neurostimulator pulse generators. The three different codes here vary slightly. So the first one here, the 95970, is basically, again, the electronic analysis without programming. The 971 is the electronic analysis with simple spinal cord peripheral nerve stimulator pulse programming. And the 95972, same thing, but the keywords here are complex. So I wanted to highlight them for you. Not that it made any difference, because I was surprised to see when I pulled this information for 2021 that these are essentially being paid very minimally on the APC side and not at all on the ASC side. I will say in 2020, there was some reimbursement attached to these on the ASC side. But again, looking at this from a 2021 perspective, of course, things change, and the payment for the ASC for these particular codes was taken away. So from a physician standpoint, doing this whether in an office or some sort of physician's facility, we can see that the 64555, I did include the RVUs and broke them down for you so that you can see the total RVUs here in this box, what the breakdown is in terms of the work expense, the malpractice expense, and then the overall practice expense, and then the total RVUs here. Okay, so big difference for this particular procedure being performed in a non-facility versus a facility. Significant price jump there, $22.74 in a non-facility versus $3.74 in a facility. Looking at the rest of the codes, the payment dropped significantly. So from this standpoint, just kind of looking at this from a broader perspective, it's going to be looking like this is going to be more lucrative to perform this in an APC setting. That's pretty much where we saw really the bulk of the reimbursement coming from, is from the APC setting, outpatient setting. ASC setting didn't look so good, and neither really does the physician setting in terms of, comparing the reimbursement amounts. But the 64590, as you can see, it has a total amount for a non-facility of $280.19. Facility is $164. The revision code ending in 85, $261 in non-facility, $146 in the facility. The 95 for their additional removal code is still $250 in the non-facility and $130 in the facility. Again, the enlisted codes are not, don't have any RVUs attached to them automatically in the Medicare physician fee schedule. But it's not to say you couldn't use it. But again, you have to understand those are going to be payer specific, and you will have to send in documents, saying what you did and all of those things to kind of prove why they should pay under that unlisted, if they're going to. All right, so even looking further at the electronic analysis codes, in a physician's office, not much reimbursement going on here. From looking at the 95970, we have $19.54 non-facility, $19.19 facility. We do have a little bit more of an increase as we go down, as we would expect so, as the 7-1 is a little bit more intricate than the 7-0, being that it is a simple spinal cord neurostimulator pulse programming, and the 7-2 is complex. So we do see the reimbursement amounts for, I guess, the level of difficulty with the code going from simple to complex. We do see that here in the payments, but it's not super significant. So again, so far it's looking like the APC outpatient is going to be our most lucrative area in terms of reimbursement. So a few key takeaways. Medicare provides coverage for peripheral nerve stimulators for chronic pain. Private payers provide varied coverage, with some affirming coverage, some denying coverage, and some are silent. Facility payment for these procedures appear to be adequate, with generous amounts for the device in the hospital outpatient setting and ASC settings, more so hospital outpatient, but we did see some reimbursement on the ASC side as well. Payment for these procedures in the physician office setting is less generous and may not be large enough to incentivize use in this setting. We saw that it's just not a whole lot of payment there on the physician office setting, but you know, it's there nonetheless. And then lastly, payers are aware of this technology and may update their policies as use continues to increase and as more evidence becomes available. Okay. Well, that is my presentation for you guys this evening. I hope you enjoyed it, and I'll be here throughout the presentation. I look forward to your questions and answers at the end. Thank you so much.
Thank you very much. That concludes our live presentation for tonight. Panelists, please turn on your videos as we move into our live Q&A sessions. Our chat function is now open for your questions, and I have some questions myself for our speakers for those who are just joining us, but certainly any questions you have will be prioritized. Good evening, everyone, wherever you may be, and thanks for joining us. I really am going to be very efficient in my question asking, and I'm going to start with Dr. Beth Darnell. Beth, you know, good to see you. It's been a while. But I think you gave a great talk. But two things, I just have two brief questions for you. One is, you mentioned for people who can't come multiple times, about a one-time visit, which sounds amazing, but it seems like I just can't wrap my head around it. And then secondly, you know, recently I put on a virtual reality headset, and I actually did a virtual reality implant that's been used to teach fellows. What do you think the future of virtual reality is for those with CRPS, and how can we use that to help people really improve?
Yeah, so I think the promise of virtual reality is incredibly exciting. And I can envision a future where we're using therapeutic VR to help recondition, including physical activity, destimulation. One of the most exciting applications for me is to consider these brief and digital interventions, virtual reality, and also the single session type treatment paired with neuromodulation and other types of procedural events to optimize post-procedural outcomes.
No, that's great thoughts. I appreciate that answer. And again, I think for rural patients, I think you hit it on the head when you said rural patients may benefit from this type of thing. I think COVID changed that too. Do you agree?
Absolutely. There is a massive need for home-based treatments and options. And, you know, this existed before COVID, but COVID revealed the essential need. And I think we have the promise of reducing pain care disparities as well by making these treatments broadly accessible and home-based.
No, I agree with you. So thanks so much for those answers. I think that's very helpful to everyone. And thanks for your time. I hope you are doing well. It's been so long. Scott, I want to ask you this question. You know, you talked a lot about mechanisms of action, and your work at Michigan has been certainly very impressive to me over the years. But, you know, recently I published a paper with Nigel McKell, Robert Levy, and about 20 other folks on closed loop and ECAPs. Where do ECAPs play into the next mechanisms that we're going to see?
Thanks, Dr. Deere. I think that's a great question. That I really like ECAPs. I think it's one of the, I mentioned the fact that one of the reasons we do computer modeling is because we have limited options in terms of studying spinal cord stimulation and its physiological effects in our patients. And so like using these ECAPs where you record the evoked activity from the other inactive electrodes on these arrays, I think is really exciting in the sense that we actually get a measure of the direct response in these patients to the stimulation. And so I think that work coming out of that from the work that you published in Lancet Neurology is really exciting. And I think we have a long way to go. I mean, clearly it shows that with some of the mechanisms, we're getting this kind of direct response in these A-beta non-pain fibers that might help with pain control through gating mechanisms. But I think there's been some other interesting observations with regards to frequency dependence and other things that I think we'll learn a lot as time goes on with regards to mechanisms using these recordings. So.
Really briefly, I submitted a new paper yesterday on the burst waveform and changing the brain. And, you know, we don't need really to map burst. So how does the brain-based waveforms figure into this equation? It's very complicated for those who are listening for the first time, probably.
Yeah, I mean, I guess shortly, I don't know. Like I mean, pain is in the brain. So ultimately the effects of the stimulation are going to have to do something that's going to be felt in the brain or some kind of change in plasticity or other things. And I think there's been some interesting work looking at using functional neuroimaging and things like that to show the effects of these stimulation waveforms and like maybe differences in how like burst or other traditional or either, you know, other high frequency waveforms might work to relieve pain. And I think the other things it shows that pain, it highlights that pain is not just a sensory problem. You have these emotional, affective aspects as cognitive aspects as well. And so I think continued work on that area and how these waveforms engage the brain activity is critical to improve the outcomes with these therapies.
Well, keep up the great work in Michigan and in regards to Parag Patel. And
I'll tell him you said hi.
Thanks a lot.
Right, thanks, Dr. Deere.
So Megan, I want to go to you next. You know, down in New Orleans. The question is, you have a person with a nerve injury at their arm. How do I know to go to peripheral nerve, which I've been doing a lot of research with recently, versus DRG, which, you know, again, cervical DRG is something I do off-label, but I think we've had great success. High frequency you mentioned, and then, or burst. I mean, how do we make decisions on what to use? What's the decision process?
So thank you, Tim. Thank you for the question. Thank you for having me. Apologize for not having my picture. I had a flight cancellation. I'm driving all the way from Texas back to New Orleans right now. So the way I approach it actually, and the way I think about it is that, you know, access to the spine, mainly, you know, if I had the option to really access the spine. So the problem in the US, you don't have the option of trialing everything. So I usually look at case-to-case basis. If you have good access to the spine, you really would be able to put a DRG or spinal cord stimulation. I think that would be my first go-to. You know, it depends again on your comfort of cervical DRG versus not. I would say if that injury was in the lower extremity, I usually tend to really think about DRG and high frequency, usually in the upper extremity. I'm not really as good as yourself or others of putting DRGs in the cervical spine. My option at that point would be utilizing high frequency stimulation. I usually utilize peripheral nerve stimulation as a second option if I could not access the spine, especially if that injury was focal neuropathic pain. I think at that point, the success was SES and DRG has been documented to be a little bit superior, with the idea of, you know, lead migration for peripheral stimulation still becoming a problem, even with the advancement of peripheral nerve stimulation. So I mainly approach it based case by case, and I had some great success in peripheral nerve stimulation, people I couldn't access the spine, and that was very helpful. And I had been very creative about where to actually insert IPGs for peripheral nerve stimulation based on, you know, mobility and other things.
You know, I think for our listeners, Dr. Megha Girgis gives a great answer that really gives you an algorithmic thought process. So Megha, drive carefully. I hope I can take you up on your invitation to have my wife and I join you at Mardi Gras at some point to give a lecture down in Oceaner. So safe travels, my friend.
Would love to. Thank you, Dr. Deere. Thank you.
My next question to Dr. Scott Kelly. Scott, you gave a great talk. I was really impressed by you. What's next, though? I mean, you talked about some studies you were doing. What's the next surgical procedures, nerve blocks? I mean, what do you explore next? Where do you think the research is going to go?
Well, the biggest unmet need is not in bunionectomy. I think we all have to acknowledge that. It's really major musculoskeletal procedures. If we talk about knee replacement, shoulder surgery, those are going to be the two largest fractions of surgical procedures where a peripheral nerve block, either a femoral nerve block or an interscalene block, if it provides durable analgesia, could have tremendous benefit to the patient. I think another link, Dr. Deere, is the idea that maybe a longer period of effective analgesia could prevent the development of these chronic pain syndromes after knee replacement or shoulder replacement. So, if this product really does live up to its potential, I think we have a real opportunity to have better patient care and outcomes.
I love your thought process. Back when I was at the University of Virginia 25 years ago during my fellowship, we were looking for the preemptive analgesia miracle. And if you have that, that would be so helpful to people to avoid chronic pain. So,
also, this idea that any opioid exposure puts them at risk for chronic opioid use. So trying to break the cycle that either leads to opioid dependence, abuse, or this idea, whatever the mechanisms are that drive chronic pain, and those are probably separate processes, right? We'd like to ideally interrupt both of those cycles.
I think that's wonderful. And I'm very impressed by your work so far. So keep up the great work.
Thanks, Dr. Deere.
Tonight and your answer. I have two questions left. I'm going to save my dear friend, Dr. Al-Saad, for last. Ms. Jasmine Pinkett, you gave a great talk. We talked about all kinds of devices. Dr. Gerges went through all those. Scott gave some great talks about the mechanism. Where should we do these procedures? I actually work in a hospital outpatient clinic. Should it be a hospital outpatient clinic? Should it be a ambulatory surgery clinic? Should it be a office? Where should we do these procedures? What's the best thing financially for the physicians to make sure they can stay viable and give patient access? Jasmine, I think you're on mute. I don't know if you were trying to
turn on your mic. Maybe move on, I guess.
Yeah, I think I'll go. Sorry about that. I think that's a great question, though, because again, the question always comes where to do the procedure, right? I think that's important. So I'll ask the last question then to my friend Al. Al, I hope you're with me right now. I'm
here. Yeah.
Good to see you, my friend, or hear you. So we talked about pediatric implants. I've done probably 20 DRG implants in teenagers, and I'd say 19 of them have done very well. I think I've had one failure, and we had to explant that patient. And I think one of the issues is, teenager years are very difficult. It's a very difficult time to be, you have all those issues with going through puberty, going through high school, and all the social issues. What's your advice to those thinking about doing an implant in a teenager? You mentioned you've done some of those yourself in Wisconsin. What's your advice? Because I think it's a very important question.
Yeah, thank you, Tim, and thanks for having me in this event. It's been always a pleasure to work with you and the crew here. I started doing pediatric spinal cord stimulation in Wisconsin. I don't think people done it before me. And my first case actually was a home run. It was all over the news. She was a teenager who basically dropping off school and living in pain, taking opioids. And her mom actually was documenting all the events. I didn't ask her to do this at all. She was just doing it. And once we did the spinal cord stimulator, she went back to school. She stopped using opioids and she got like A+ and everything, went to college. And they just changed her battery literally, I think 1 or 2 years ago. And she continues to have the same system. We didn't even have to do any revisions. I did it. She was 16. So now she's probably around 21, but it's a life change. So I encourage people, teenagers usually will be the candidates. They are like adults. If you feel everything else, if your life is falling apart, it's really worth it a try. And I want to say almost all the cases we did here did very well. It's an option that can get those kids back to life.
I like what you said. And I think the fact you said a 16-year-old girl, I think when the growth plates, close, that's a good time to do the implant, because I did have one young man that was 12, and as he grew, we had to go back and do a couple of revisions because his body changed so much. And so I think when the growth changed, that's a really important point. So, and I also think that I love what you said about involving the mother. and the family, because it's so important to have the family buy into the therapy. So I think what you're doing there is really strong work. With that, I know we're right on time. I think now we cut back up on our timeline. And I'd like to thank everyone for joining us. Thank our faculty. What a great job you all did. And I hope everyone had great benefit from this talk. And I want to thank the Allegheny system for having this event. With that, I wish you all a great night and a great week. Thank you very much to all the speakers today. It's been an excellent program. And most importantly, thank you for the attendees who participated in this excellent masterclass. I think it's going to be helpful to your practice, helpful to patients, and hopefully it'll be impactful to those who cross your path as you go on this journey of treating pain patients, which can be rewarding but challenging. Our next accredited masterclass will be on the topic of current concepts in sports medicine, which as an ultra runner and triathlete, I found very exciting. That will occur in June. I hope to see you all there. Goodbye. Have a wonderful night.